the medical management of adenomyosis. So, what exactly is this disorder called adenomyosis? Adenomyosis is one of the common gynecological disorders for which a person comes to the gynecology OPD with a complaint of abnormal uterine bleeding. So, abnormal uterine bleeding is one of the commonest reasons a woman visits an OPD, a gynecology hospital. And among the different causes of abnormal uterine bleeding, one of the important organic causes that we will notice is this condition called adenomyosis. So, what exactly is adenomyosis? Adenomyosis is a disorder of the uterus where there is the presence of endometrial glands and stroma within the myometrium. And this results in enlarging of the uterus and symptoms like dysmenorrhea and heavy menstrual bleeding. This is a disorder that is a estrogen dependent disorder, primarily affecting reproductive women. So people around the age group of 35 to 50, 25 to 40 are going to be affected more. Usually a little bit on the higher side, maybe 35 to 50 is also more commonly involved than younger women. But off late, we are seeing more of even young women having adenomyosis. And many often, the only symptom they have is heavy menstrual bleeding. They could also complain of pain. And you would also notice that some of the patients who have infertility, one of the reasons for infertility is adenomyosis. And although this adenomyosis is usually a disorder of multiparous women, nowadays we are seeing more of younger nulliparous women who have never even had never become pregnant in the past, and who come with infertility, and then we identify that there is adenomyosis, the cause of the infertility. Okay, and as I said, it is estrogen dependent, and sometimes adenomyosis can occur along with endometriosis, or it can occur along with fibroids. And the exact treatment for this condition is hysterectomy. But again, hysterectomy is not really a solution because of the simple reason that it is occurring in the reproductive age group. So, a lot of times they have not even completed family, or they are obviously a hysterectomy has a larger implication. So, and it would not be very an optimal option, and it is used more as a last resort. So if you look at the epidemiology of this disease, around 20 to 35% of women undergoing hysterectomy, they say, for different gynecological symptoms, will have a adenomyosis lesion in the uterus. So it is most common in this age group of 35 to 50, more common in multiparous women and women who have had previous surgeries, particularly C-sections. And often it is very difficult to diagnose adenomyosis because the symptoms overlap with many other gynecological disorders. And I'm not going into the details of the pathophysiology, just want to tell you that the endometrial lining, this tissue, and we have the uterus, the inner lining, which is called endometrium, then the myometrium, and then we have the perimetrium. So when the endometrial lining, those glands enter inside the myometrium, then we call it as adenomyosis. So you can see here, this is a normal uterus. This is the uterus with adenomyosis. So you can see the endometrial glands within the myometrium. And so whenever the patient goes through the menstruation, all these glands also will enlarge. There will be proliferation of these glands, and that will lead to a lot of pain and other symptoms that the patient usually experiences. So there are various theories that are proposed. One of the longest or most widely accepted theory is the hyperestrogenism environment. Okay, which basically the theory states that because there is a lot of estrogen production, that is what is leading to some of these endometrial glands proliferating and going towards the myometrium. And mechanical strain and local aromatization are also other theories. So most women with adenomyosis usually have this disease occurring between 35 to 50, and many women have given birth to more than one child. And because endometrial tissue could invade the myometrium even when an embryo implants in the uterine wall. So that is why it's connected to multiparous pregnancy and multiparous women. And previous surgeries, okay, studies suggest that prior uterine surgeries are more likely to make a person have a adenomyosis because of the traumatization of the uterus that happens during surgery. It could act as a trigger for the endometrial glands to invade into the myometrium because of the weakness of the endometrial wall. And hormonal fluctuations can also cause the development of this adenomyotic foci. So, what are the common symptoms? People could complain of abdominal symptoms like bloating, fullness, and on sometimes they will have, even when the adenomyosis is quite big, they could complain of swelling in the abdomen, but though that is not very common. And menorrhagia, heavy menstrual bleeding, this is the most common symptom. Heavy bleeding during periods, and they could also complain of severe cramps during periods. So dysmenorrhea, menorrhagia, these are the two commonest symptoms that occur in patients with adenomyosis. Pelvic pain, chronic pelvic pain that is persistent, that is often persistent, that is also could be one of the presentations of adenomyosis. One of the less common symptoms of adenomyosis is dyspareunia, that is pain during sexual intercourse. So the diagnosis mainly is a clinical diagnosis. And if you want to confirm that a patient has adenomyosis, obviously you will have to take a histopathological examination, and that is only possible in the operating table during surgery. If at all there is a extraction of the lesion, then you can take that lesion out and then you can confirm it by histopathology. So most of the time, diagnosis is made by clinical diagnosis only, along with imaging. So imaging, which are the imaging done? Ultrasound, CT, and MRI. Usually ultrasound imaging is sufficient to diagnose adenomyosis. So what are the treatment goals? The most important factor when considering the treatment of patient is about what is the status of her fertility. Is this person a completed family or is a person not completed family? That is a very major factor. So because the definitive treatment, if a patient is not responding to all the medical management, then the only resort is to go for surgery. And of course, in surgery also there are different options now available. But then the ultimate treatment is completely removing the uterus, especially when the adenomyosis is quite extensive, where it is not possible to really perform a selective surgery to remove the adenomyotic lesions. When it is very extensive, then the only resort is hysterectomy. But in patients who want to preserve the uterus for or those who are younger patients who desire future fertility, they are not obviously a candidate for surgery. And then the only option left for us is to go for medical management. So medical management of adenomyosis is very important because even though the definite treatment is surgery, it is not really an option for most of the patients. And then we have a number of drugs that are available, and those drugs is what we are going to see for the next 10 to 15 minutes. So we have non-steroidal anti-inflammatory drugs, non-steroidal anti-inflammatory drugs. So non-steroidal anti-inflammatory drugs, as you all know, are one of the commonest group of drugs that are used for pain and for dysmenorrhea, particularly, and even in healthy women also. When the dysmenorrhea is quite severe, they resort to NSAIDs. And this NSAIDs have been very useful even in the dysmenorrhea that is associated with adenomyosis. In mild adenomyosis with pain, dysmenorrhea, NSAIDs are found to be very useful because dysmenorrhea is also associated with release of a lot of prostaglandins. Having a drug like NSAIDs will obviously help in reducing this severe cramps that occur. By inhibiting the COX-1 enzyme and the COX-2 enzyme, they are which are necessary for the conversion of arachidonic acid into prostaglandin. The prostaglandin synthesis is inhibited, and thereby the amount of pain that a patient has is reduced. So it is effective against mild pain. And another big advantage with this drug is it is not a hormonal drug. So, okay, the chances of certain complications that are usually present with hormonal drugs can be avoided. and of course, it is obviously not going to interfere with fertility. So it can be useful in patients who are wishing to conceive, who don't want to affect their fertility to be affected. In such patients, NSAIDs are a good option. Okay, but of course, we all know NSAIDs are not the safest drugs. There are some patients who do not tolerate NSAIDs, and especially when you use NSAIDs for long-term use of NSAIDs are known to cause side effects. Okay, particularly the gastritis can be quite severe in some patients. Some patients, when it is long-standing use of NSAIDs, can also cause analgesic nephropathy. So these are long-term side effects that are known to occur. So one should be careful about all these things. And again, NSAID at the end of the day is going to cause symptomatic relief. And a person who's having pain along with heavy menstrual bleeding, NSAID is clearly not a solution, because NSAIDs are only going to help in reducing the cramps, but the heavy bleeding is going to continue. So NSAIDs may not be a frontline option in a patient for whom menstrual bleeding is the main symptom, heavy menstrual bleeding, HMB. If the HMB is the main symptom of adenomyosis, NSAIDs are not really useful in that context. Then we have the combined oral contraceptive pills, which are used for obviously for contraception. So these drugs are also found to be useful in adenomyosis. Okay, so a patient who's on OCPs, obviously, it is going to help them in alleviating even the adenomyotic symptoms. Okay, so they act how basically these drugs act. They inhibit the FSH, LH, and they block the follicle development and endometrial proliferation. So all the adenomyosis symptoms that is occurring are obviously relieved. It can be effective in relieving the pain, and it compared to other drugs, the side effects are much lesser. But again, the efficacy in reducing the uterine volume is relatively less. And we all know oral contraceptive pills have this problem. That is, in patients who are above 40 years of age, who are already at a risk for thromboembolic phenomena, it is not a very wise choice to give them oral contraceptive pills for a long period of time. So it can increase the risk of thromboembolic phenomenon. So it can be avoided in people who are slightly older. Then we have another group of drugs, namely the progestins. They also have the contraceptive effects and thereby make the uterus non-receptive to embryos and implantation. They have the ability to suppress FSH/LH and inhibits the ovarian steroid formation. So the main advantage is the estrogen hyperestrogenism that happens is countered by progestin, and pain is very much reduced. And this is something where you can give the drug for a much longer period of time also. Okay, but it might not be very effective in reducing the uterine volume, and it is some patients do not get relief at all, and frequently it can also cause metorrhagia at varying severity. Next, we have a drug called ulipristal acetate, which is a progesterone receptor modulator that is used for different conditions, including emergency contraception and uterine fibroids. So this drug is helpful in delaying the ovulation and endometrial maturation, and by lowering the estradiol levels. So it reduces heavy menstrual bleeding. So it is obviously one of the few drugs which act in patients with heavy menstrual bleeding. But the disadvantage is some people do report that the symptoms are worsening with treatment with ulipristal acetate, and pain as such is not reduced much with ulipristal acetate. And there are some patients who also see that after starting ulipristal acetate, if they go for an ultrasound, they'll find that the ultrasound lesion, it looks much bigger than the earlier. So in terms of radiological improvement, you will not see much of radiological improvement. So probably the lesion stays, but the symptoms kind of subside. That is what you're seeing with ulipristal. And then we have the GnRH agonists. They are drugs which competitively bind to the natural GnRH receptor, And these drugs are very useful in suppressing the GnRH secretion and the subsequent decline in estradiol. They alleviate the pain, they induce almost a situation like an amenorrhea, reduce the volume of the uterus, because some patients with adenomyosis, especially if you're dealing with a extensive adenomyosis where much of the myometrium is involved, then the uterine volume as such is going to grossly increase. And that is obviously reduced when you're giving GnRH agonists. And it is also useful, particularly in the context of people who are undergoing infertility treatment. So when we are initially starting the infertility treatment for some of these patients, the GnRH agonists are given for a brief period, okay, to reduce the adenomyotic lesions. And disadvantage of this drug is there could be flare-up, sometimes worsening of the symptoms, and severe hypoestrogenic side effects can occur. For example, vasomotor syndrome, loss of bone mineral density, and so long-term use is not really indicated. So the drugs we have is triptorelin, leuprolide, goserelin. And then we have drugs like GnRH antagonists, which are drugs that antagonize the binding of the GnRH to the GnRH receptors, and they cause dose-dependent suppression of FSH and LH. The major advantage is this is an oral drug, unlike the GnRH agonists, which are given by no parenteral route, and it has a rapid action within 1 to 2 weeks. You can see the effect, and it is also effective in reducing the heavy menstrual bleeding and the pain symptoms. Okay, and disadvantage is that loss of bone mineral density occurs at high doses, and the drugs that are available in this are mainly linzagolix and elagolix. So some of the recent treatments that are now coming up is one is we are looking at other drugs besides hormones which can be effective. And then they have seen that a drug called bromocriptine, which is used in patients with Parkinsonism, it is a dopamine agonist. It can also be useful because some of these patients with adenomyosis, there is a theory which states that the hyperprolactinemia that is there in patients with adenomyosis, that is can be suppressed to a large extent, and indirectly that helps in reducing the adenomyotic lesions. Similarly, we have a drug called ozagrel, which is an antiplatelet drug that is found to lessen uterine contractility, hyperalgesia, and immune cell infiltration in animal models of adenomyosis. And then we talk about another interesting drug. I come to the last part of my talk. So there is this drug called cabergoline, which is again a drug used in patients with Parkinsonism, a dopamine receptor antagonist, which is known to have reducing the activity of estrogen. How? Because it inhibits the vascular endothelial growth factor expression. When you're suppressing vascular endothelial growth factor expression, what happens is it automatically helps in suppressing adenomyotic lesions, because the intralesional vascularity, basically you are depriving the adenomyotic lesions from getting good blood supply. So, and that will indirectly curb the adenomyotic lesions. So giving cabergoline, we had done a clinical trial almost a year back, and we have now submitted that article to a journal. It's right now under review. And so we have found that even in our own study, the drug was able to reduce the pain, it was able to reduce the bleeding also, and most importantly, they did not complain of other side effects. Okay, and patients did have good tolerance to this drug. This was one drug that didn't have to be taken on a daily basis. Weekly, just 2 doses had to be given. And the potential for uterine shrinkage was also visible. It was able to reduce the uterine size and myomas also. And as such, the tolerability is good. So this is one very promising drug. Again, not enough studies are done on this. So we will probably see in the days ahead more studies with bromocriptine and cabergoline, which can supplement the other drugs which are regularly being used. So to conclude, I would say that adenomyosis continues to be a very enigmatic disease. A lot of time people get stuck in diagnosis, people get stuck in giving the best optimal treatment. Although surgical treatment is definitive, it is not an option mostly. And the drugs that are medically used are, we have the NSAIDs, contraceptives, progestins, ulipristal, GnRH agonists, GnRH antagonists. So all these drugs are found to have, I should say, considerable degree of efficacy for reducing pain and also for bleeding. And the exact choice will be based on the particular context of what is the medical history of the patient. Accordingly, right choices should be taken when you decide to give treatment for adenomyosis. So with that, I end my presentation.